Welcome to The Explainer. Today we are jumping right into a really complex and honestly fascinating part of psychiatry. We're using Chapter 9 of a short textbook of psychiatry to help us understand the disorders of adult personality and behavior.
So let's start with the most basic question of all. We all have our quirks, right? Our own unique ways of being. But where does psychiatry actually draw the line between just having a certain personality type and having a clinically recognized personality disorder? How do they make that call?
All right, here's our game plan. First, we'll look at the official definition of what makes a personality a disorder. Then, we'll see how these conditions are grouped together, which is super helpful. We're even going to zoom in on one of those groups before exploring some other related and pretty interesting conditions. This should give us a really clear roadmap.
Okay, let's get right into it. Section 1. We're going to figure out exactly when a set of behaviors stops being just, part of who someone is and crosses that line, that clinical line in the sand, to become a diagnosis.
So, according to our source, the definition is really specific. First off, and this is crucial, these conditions aren't caused by something like brain damage or another mental illness. The real heart of the diagnosis is in what it calls markedly disharmonious attitudes and behavior.
The ICD-10, that's the big international guide for diseases, gives clinicians a kind of checklist. It's not enough for the behavior to be disharmonious. It has to be an enduring, long-standing pattern. We're not talking about a bad month. It also has to be pervasive, meaning it shows up across all kinds of different situations, and it has to be clearly maladaptive. It just doesn't work well for the person. And, importantly, the roots of it usually show up way back in childhood or adolescence, and it's causing real, significant personal distress.
Okay, so with all these different potential disorders, how do psychiatrists even begin to organize them? Well, they use this really helpful framework that groups everything into 3 main categories, or clusters.
And here it is. This is the system that brings some order to the chaos. You've got Cluster A, which is kind of nicknamed the odd and eccentric group. Then there's Cluster B, the dramatic, emotional, and erratic group. And finally, Cluster C, which covers the anxious and fearful types. This simple breakdown gives us a fantastic mental map of the whole landscape.
Now, to really get a handle on this, let's put one of these clusters under the microscope. We're going to zoom right in on Cluster B. That's the one described as dramatic, emotional, and erratic. Our textbook uses a pretty powerful phrase for this group. It says these disorders exist on a psychopathic continuum. Now, that's a heavy term, but it really speaks to the core features you see here. Behaviors that can be incredibly intense, often unstable, and highly unpredictable.
So what does that actually look like? Well, let's take a really well-known example from Cluster B, the borderline type of emotionally unstable personality disorder. You can see right in the definition, it's all about a turbulent inner world. We're talking instability in emotions, in relationships, and even in a person's very sense of who they are.
And when you look at the specific features, you really get a sense of this experience. There's this chronic, gnawing feeling of emptiness, which can fuel this desperate fear of abandonment. You often see patterns of self-harm and relationships that are incredibly intense, but also really unstable. And at the core of it all, this profound disturbance of identity, that feeling of just not knowing who you are from one moment to the next.
Okay, let's shift gears a little. The chapter also talks about a different group of conditions. These aren't so much about the entire structure of someone's personality. Instead, they're about very specific, repetitive behaviors where a person feels a complete loss of control.
These disorders all follow this really powerful 3-part cycle. First, there's this building feeling of tension. It just grows and grows. Then, that tension leads to an impulsive act that the person feels is completely irresistible. And finally, right after the act, there's this feeling of relief or even gratification. It's a very potent loop.
A perfect example of this is pathological gambling. The person has this intense, overwhelming urge to gamble, and they keep doing it, even when it's causing chaos in their life and a ton of personal distress. The problem isn't the gambling itself, it's the uncontrollable compulsion driving it. Next up, pyromania. And you see the exact same pattern. This isn't arson for money or revenge or some other external reason. The motive is purely internal. This intense urge to set fires, which follows that same script. Tension before and a sense of relief after.
And it's the same story with kleptomania. A person steals things, not because they need them, not for their value, but simply to satisfy that powerful internal urge. And just like the others, completing the act brings that temporary feeling of release.
All right, our final section covers a really fascinating and I think widely misunderstood condition. Our source text even has a nickname for it, the professional patient. This is factitious disorder, which you might know by its other name, Munchausen syndrome. And the defining feature here, the absolute key, is that people will fake or even cause real physical symptoms in themselves for one reason and one reason only: to get medical attention and to be in that sick role. Now, this is maybe the most important distinction to make. It all comes down to the why. With factitious disorder, the motive is internal. It's a deep psychological need to be seen as a patient. That's completely different from what's called malingering, where someone fakes being sick for a clear external prize like getting an insurance payout or getting out of work. The motive is everything.
This quote from the textbook is just, wow. It's so vivid, and it really drives home how severe this can be. People might put themselves through countless, painful, unnecessary medical procedures. It can get to the point where there's physical evidence, like what's described here as a gridiron abdomen from having so many exploratory surgeries.
So, after all that, what are the big ideas we should walk away with? Well, first, that personality disorders aren't just quirks. They are deep, long-term, maladaptive patterns. Second, that three-cluster system, the odd, the dramatic, and the anxious, is a really useful way to think about them. And finally, that there are these other related conditions, like impulse disorders and factitious disorder, that are all about specific behavioral cycles and motivations. And we'll end on a big question for you to think about. Systems like the ones we've talked about are absolutely vital for doctors to diagnose and treat people effectively, no question. But they also bring up this really profound issue. As we get better at defining and categorizing these incredibly complex human experiences, how do we make sure we strike the right balance? How do we get the clinical clarity we need without falling into the trap of just slapping labels on people? It's something we're thinking about.